Thanks for joining us for another episode of Clinician's Brief, the podcast, the conversations behind the content. I'm your host, Dr. Alyssa Watson, and I'm excited today to welcome back to the show Dr. DJ Haeussler. Dr. Haeussler is a veterinary ophthalmologist and the founder and owner of the Animal Eye Institute. He's authored multiple articles for Clinician's Brief over the years, and he's also a veteran Clinician's Brief podcast guest, having been on the show 2 times before. So we're so excited to have you back. How are you doing this evening?
I'm doing great. Thanks for having me back again. I appreciate it. I always like working with you guys.
Yeah, well, we're excited to have you. We're going to be talking all about enucleation in the dog and the cat today. But before that, if you could take a minute, introduce yourself to the audience. For those of them that didn't get a chance to hear your earlier episodes, tell us a little bit about your background. We would appreciate it.
Sure. So my name is Dr. DJ Haeussler. I'm a board certified ophthalmologist. I'm located primarily in the Cincinnati and surrounding community areas. I have offices in Cincinnati, Dayton, Florence, Kentucky, and we just recently opened another branch or office in Charleston, Mount Pleasant, South Carolina. Let's see, I graduated from Ohio State with my Bachelor of Science as well as my DVM, and then went to Garden State Vet Specialists and did 2 one-year internships out there. And then I came back to Ohio State and got my master's degree as well as doing a residency, and finished that up, and then became board certified. And I opened the Animal Eye Institute directly after graduation in 2011.
Well, that's great. And congratulations on the new location.
Thanks. Yeah, it's a lot of fun. Scary and fun.
Yeah, well, moving forward. So let's talk about enucleation. Okay, this definitely is one of the more common procedures that, I as a general practitioner will do, one of the more common ophthalmic procedures. What are some frequent indications for enucleation in the dog and the cat?
Yeah, so that's a good question. So the most frequent reasons for enucleation is either a corneal rupture that can't be repaired through a grafting technique, or shouldn't be repaired through a grafting technique, such as if if the animal has lost its menace and its dazzle response, which basically means that their retina has detached through this as a process of this rupture. That's probably the most common. Second would most likely be intractable glaucoma. And so animals that have failed medical management through glaucoma, there's no more options left. They're uncomfortable. And so an enucleation is warranted at that time. And then also intraocular tumors is probably the furthest one down on the list, but occasionally we see intraocular tumors, and we don't know what they are because you can't biopsy them within the eye. And so enucleation with biopsy is warranted at that point.
Sure. That makes total sense. And that's kind of, where I'm always focusing too. So if I have a blind eye that I know is painful and causing problems, that's when I start to talk to the owner a little bit about enucleation. I do find that the very idea of enucleation is sometimes upsetting to clients, though. How do you kind of approach the issue of client acceptance of a pet losing their eye?
That's a good question. So we take it pretty gently because it's very routine for us. Obviously, we do them almost daily, but obviously that can be a very, very traumatic experience for a client. And so honestly, if it's a rupture, they kind of seem to be more open to it because sometimes there's blood involved, a higher pain level. Potentially the iris is kind of sticking out of the cornea. And so they know it's a bad issue, or they saw their veterinarian and their veterinarian referred them and said, go see them and see if this can be repaired, or if they have to do an enucleation. In terms of glaucoma, we try to kind of set them up for it to begin with. Once they start increasing the meds and the frequency of glaucoma, we start saying, like, giving them a timeline, like if these pressures don't come down using these medications with this follow-up time, we need to start talking about enucleation. So those are kind of the most common ways that we do it. But I would say, I think that we all kind of change our tone and our approach in a situation like an enucleation, because it's not an easy discussion. If you're talking about an intraocular tumor, I usually will tell them this is what's indicated. But if you want a couple weeks to decide, or think about it, let it kind of settle in, that's a prudent approach for them, because it's a big deal.
Yeah, it is definitely a big deal. The surgery itself too can sometimes, there's some pretty significant complications that can happen with this surgery. Um, we're going to talk about today's podcast is really about the transpalpebral technique, and we're going to talk about that and go through the actual process, the surgical steps. But regardless of which technique you use, what are some complications of enucleation?
The most common one that we see would be an incision dehiscence from the animal pulling the stitches out on their own, and this is mostly a client issue where they take the e-collar off. They don't like the e-collar, or they switch the cone type e-collar to an inner tube type e-collar, and then the patient can still get to the wound that way with their paws, and so they'll pull their stitches out, and you'll have a dehiscence, and so that's probably the most common. Other ones are, you can develop any sort of orbital abscesses or fistulous draining tracts. And then another common one that we would see is if there's retained conjunctival tissue within the orbit, over time, it will create essentially a cyst within the orbit, because it's a secretory tissue, and you'll get a fluid filled cyst, and you'll end up having to go back in and do an exenteration, which is removing everything from the orbit that you can.
Right, right. Yeah, unfortunately, I have seen that one before,
Yeah.
where the socket, fills up with secretory fluid. Let's talk a little bit about the subconjunctival approach, because that, while we're going to talk in detail about the transpalpebral approach, the subconjunctival approach is one that I honestly routinely use. I've used that one more. That's the one I feel a little bit more comfortable with. But there's definitely some times when it's not indicated. So, can you summarize the main differences between the two techniques?
Yeah, the main difference really is a transpalpebral approach. You are closing the eyelids prior to making any sort of incisions. The subconjunctival approach is more removing the eyeball as it essentially looks at you, and then going back secondarily and removing the tarsal edges of the eyelid. So that's the main difference.
And like I had said, and you mentioned in the article, there are some times where that subconjunctival approach is really contraindicated. So those would be things, you listed out like infection, infection of the conjunctiva, neoplasia of some of the extraocular surface, or corneal perforation. But are there times when you prefer that subconjunctival approach to the transpalpebral?
For me, no. I personally prefer the transpalpebral approach. I think it's personal preference. It's the way I was trained. We routinely train students this way. When I was at Ohio State, I was told that it has less of a complication rate than a subconjunctival approach. But it's like anything. What works for you over time, and if minimal complications, either one is fine. So it a lot of times it just comes down to personal preference.
That's actually really good to know. So, is there any time where the transpalpebral approach is contraindicated?
I can't think of one. I can't think of one at all. It's I've used it. I use it routinely for basically everything when I'm doing them. So I can't think of one.
So we know we're always safe to stick with that one.
Yeah, you are.
Good. Okay. So let's turn our attention a little bit to pain control. So obviously the eye is very abundantly innervated. Oftentimes these patients have been experiencing ocular pain, like you said, with glaucoma, that, could have been going on for a good amount of time prior to the procedure. So I think everybody is on the same page that local anesthetics are really wonderful here. I oftentimes use like a splash block in the eye in the orbit after the eye's been removed. But do you think that that is really inferior? Should we be doing something like retrobulbar blocks?
Yeah, the a retrobulbar block is shown to be more effective than a splash block. There's a paper by Christina Plug and Rob Swinger uh, out of JAVMA in 2014 where they've shown this. So I think a retrobulbar block is well, it's been shown to be more effective, and that's what we use routinely as well.
And then what kind of volumes are you using in those blocks? Are we worried at all about toxicity when we have little patients or cats, small dogs or
Um,
cats?
You shouldn't be if you're using the correct dosages, which are also listed in the paper, which is if they're less than 15 kgs, you can use a mil of lidocaine and a mil of bupivacaine. If they're over 15 kgs, then 1.5 mils of lidocaine and 1.5 mils of bupivacaine.
Okay. And then you also talked in this article about these intraorbital lidocaine bupivacaine infused absorbable gelatin sponges. I had never heard of that. Are these commercially available?
They are, yeah. They're commercially available through your major distributors. They're used in neurosurgery and also ophthalmology, and it reduces the dead space. So you don't have such a big seroma, hopefully, and I'm hoping that by doing that we're reducing the animal's pain as well.
Sure,
So it kind of
absolutely.
acts like a delayed splash block, to be honest with you.
Yeah. Do you think, I mean, can you like do it yourself with these? Could you take something like a gel foam product or something and infuse some lidocaine or bupivacaine in it and pack that in there?
Oh, I'm sorry. So yeah, so they sell the sponges, and then all you
Yeah,
have to do is put like 3 mLs on it when it's like on your table. So they come in these. They essentially look like envelopes, and so you open the envelope and then just have your tech squirt the syringe directly on the sponge.
perfect. Okay, yeah. That's kind of what I figured was going on there, but I wasn't 100% sure.
Yeah, so it's like quasi DIY. You can do it yourself. They provide the sponge, I provide the block, and we're happy campers.
Finding practical CE can feel like discovering hidden treasure. Clinician's Brief has a trove of more than 60 hours on demand and ready for your next dive into CE. Courses are race approved and laser focused on giving you clinically relevant insights and skills. Your next course is waiting at cliniciansbrief.com/CE. So let's go ahead and talk about the actual procedure for the transpalpebral enucleation. This article, people can find it either online or in the print edition of Clinician's Brief. And there's a nice list of suggested materials, and most of them are pretty common. There are things like gauze and a sterile bowl, but there are a few specific ophthalmic instruments. So what instruments do you think are absolutely vital when you're going to perform an enucleation?
Yeah, and thanks again for everybody that's reading it. I'd be remiss if I didn't say thank you to Dr. Carrie Gonzalez who wrote most of this art, all of the article, and I supply photos and edits and things like that. So she did a really nice job, and it was a fun project to work on. I would say that the most common that you really need is Stevens tenotomy scissors, which are just scissors specifically for ophthalmic surgery. Bishop Harmon forceps are a little less traumatic than like Brown Adson's. So I'd say those are probably your two main ones.
Okay. And then for suture type, because this is something that a lot of people always have questions, is there a type of suture and a size of suture that you prefer?
Yeah, I use 4-aught Vicryl to close the subcutaneous layer, and then I use 6-aught Prolene to close the skin layer. I would
Okay,
say
so
one of the more common complications or issues that we see is suture that's too large being used. The larger the suture is, the more there's tissue reaction, which then will cause the patient to be irritated and therefore try to get the e-collar off or try to open it up. So, using something like gut or 2 or 3-aught PDS is just not really appropriate. The smaller the suture that you can use, essentially hides it from the body and will make them more comfortable and will give them less of a scar.
and do you find that those braided sutures are a little softer in as well when you're using the Vicryl?
Yeah, I guess they're a little bit softer. I don't know that I've
Okay.
ever really truly paid attention to it, but yeah, I guess they are a little softer.
Is there any advantage to placing the patient in lateral recumbency with the affected eye up as opposed to sternal recumbency? I know I've seen people, suggest both ways.
I don't think there's an advantage either way. I think it's personal preference. I do lateral, but with the eye upward, but I've seen people do them sternal and they both work. So however you're trained and whatever works best for you, I think is acceptable.
And then what are you using to irrigate the ocular structures before surgery?
Dilute betadine. So we
Okay.
just use a dilute betadine, and kind of hose the eye out after we clip it. So we clip it prior, and then kind of hose all the extra hairs that may end up like on the ocular surface or in the conjunctival fornices, and then yeah, and then we kind of go around the eyelids with a betadine swab.
Okay. And then, as you said, the real difference between these two procedures is that you start the transpalpebral by suturing the eyelids closed, either with sutures or you said you can use staples. Um, and then you incise all the way around the lids. Is there any way to, like, if you potentially incise too far from the lid margin, can you cause complications that way?
Yeah, you would have a bigger issue with cats or horses if you're too far away from the eyelid margin because their skin is much tighter.
Okay.
So if, for instance, if you staple the eyelids, those staples will actually give you a perfect distance. If you just hug those staples with your scalpel blade, then you'll have plenty of ability to close anything really. Sutures, they might be a little bit tighter based on where you put them, but if you should be 3 to 4 millimeters from the eyelid margin.
Okay. That's a great tip. I love little tips and tricks like that. So
Yeah,
just follow the staple line.
yeah, just hug the staple line, you'll be fine.
So then we do need to grab those Stevens tenotomy scissors, like you said, and you start to just carefully dissect around the globe. Do you always have a place where you start? Do you start dorsally? Do you start ventrally? Does it matter? Again, is this just preference?
Yeah, so after I, make incisions and then kind of work the tissue back with a scalpel blade, and I also use Alice tissue forceps to kind of grab those eyelids. Once you kind of work back through the conjunctiva, then you grab your Stevens tenotomy. I usually start dorsolateral on the eye just because there's the least amount of stuff going on there. Ventral, you're obviously going to be moving your hand in somewhat of an awkward position. If you're medial, then you're going to be messing with a third eyelid a little bit too early. So if you go dorsal lateral, you have less stuff to start your incision.
And then you want to stay in a plane of dissection that's just superficial to the conjunctiva. Um, so, what happens if you go too deep, if you're not in that plane?
Yeah, if you go too deep, you could poke a hole through the conjunctiva, which then you're risking that you're going to leave some conjunctiva behind, and then end up with one of those complications like an orbital cyst. If you're a little bit too aggressive with your blade, you could end up cutting into the globe, which may influence your biopsy results to some extent. I guess those would be your two main complications.
Okay. So I find that transecting the optic nerve is one of the more difficult parts of this surgery because, it's basically done blindly. I think that also another thing that I see a lot of debate about is whether or not you need to ligate that optic nerve. So what are your opinions on that?
You don't have to ligate the optic nerve. I get
Okay.
asked that a lot when I lecture. You don't have to ligate it. That's old literature. Don't do it. And that's always what everyone thinks is the most annoying and frustrating part. You can't get your fingers down in there, and it's hard to get instruments. And how do you know you're wrapping the optic nerve? And you don't have to do it. So,
Okay.
so don't do it, and your
So
job will be easier.
that's great. Anything that makes it easier is better.
Yeah.
This is also the point. I think the reason that this part of the surgery makes me nervous is when I'm trying to get back there to transect that nerve, I'm worried about placing too much traction on the globe because I know that you could potentially cause vision loss in the contralateral eye. Is this complication? I mean, how often does that really happen? It's never happened to me, thank goodness.
It's not common, because everyone is very aware of this. They teach it in universities. It's one of those things that just seems to sit in everybody's head, of this is a massive complication. Don't let this happen to you. So no matter if you're into ophthalmology or not into ophthalmology, everyone seems to recognize this issue. Cats are the ones that are most at risk for this. So you basically just have to be cognizant of what you're doing. And if you are a solo surgeon and you're grasping like the eyelid margins with the Alice tissue forceps and using your other hand behind the eye, just don't put too much traction. You should be, if you're using Stevens tenotomy scissors, you should be able to get back there and cut without having to do any sort of very, very minimal traction right there.
Okay. And then after they recover, how quickly can you check the remaining eye for vision, or how quickly would you know that there was a problem?
You would know that there's a problem pretty quickly. I mean, once they're kind of conscious and standing on their own four legs, you should be able to check a vision response. So they also would likely be midriatic. Their pupil would be dilated, and so yeah, it's you would know before they left your hospital.
Okay. And then the final step in the procedure is closure. And so I've always heard that a three-layer closure is necessary, but in this article, you describe closing the deep fascial layers and then the subcutaneous layer tissue together. Um, I'll be honest here too. Oftentimes, once I get to this point and the eye's out, it's kind of just a big crater. Sometimes I've put some gel foam or something in there to, control a little oozing. So it's sometimes difficult for me to even differentiate the layers and where I need to be suturing. Um, is it really critical that you get some of that periosteum to make that mesh pattern with the deep closure, or how do you suggest doing this?
If it's critical, then I'm messing up my own surgeries, so I don't do it. I
Okay.
don't grab periosteum. I don't really think. Well, I know you don't have to make a mesh or anything across the orbit. I don't put implants in terms of for enucleations. That's just a personal preference of mine. I tell my clients that it's likely going to sink. The skin will sink in. I don't believe in putting in a lot of extra stuff that's non-absorbable, like using a non-absorbable to make a mesh. I've seen people do that, or putting some mesh type work in there to prevent it. I you know I don't like that stuff at all. It all puts you at a greater risk of complications, infections, and so I just tell the clients beforehand that if they're a dolichocephalic breed, you're gonna notice it's gonna sink. If they're a brachycephalic, you may not notice. It may not sink that much. So I just do a two layer closure. I'm not too concerned about the layers really. It's really just a sub Q layer and then a skin layer.
Excellent. And again, managing those client expectations with a lot of communication, it sounds like is just really important.
Yeah, that I think goes a long way, as we all know, or at least as we all should know.
So, do you have any other postoperative tips that would like the audience to know?
I think the biggest post-operative one is some different tips would be to impress upon your clients the necessity of leaving the e-collar on at all times. If you take the e-collar off just simply so the animal can eat, that one swipe can grab those stitches and pull those out. Um, Swelling is okay. I saw there was a post on a social media site the other day where somebody had some swelling afterwards, and they were really worried about it. And I commented like, yeah, that looks like any of the ones that I've done. Like it'll be totally fine. It's a seroma. They get blood there. It'll happen. Don't let it freak you out. It'll go away. Warn your owners that it's there and it'll go away. You can get some leakage of blood. You especially will see it when you give the dog or cat back to the owner on discharge. They get really excited and their blood pressure goes up and their heart gets going, and they'll break some of those scabs and they'll bleed out their incision, and owners may get worried about that. So just tell them that that's completely normal. And then you'll also get blood that can filter through the same side nostril, and so they may sneeze, and then the owner will notice blood. Also completely normal to have a couple drops of blood on the same side nostril for a few days after surgery, and not to be too concerned with it.
And can you give the clients some things to do in those situations? Like, does it help to compress them? Do you suggest?
You can compress them. Warm compresses work really well. Not having white carpets or white furniture would be a
Would be
suggestion.
preferable.
Yeah, it would be preferable if you, but you might be okay if you had like red carpet or red couches. But no, it's mostly just warm compresses, supportive care, and honestly, like it's such a big deal for clients, and it should be that just keep your lines of communication open. Whether it's social media channels or email or phone calls, so that they feel supported through the whole process.
Well, I think it's great that you will take the time to comment and help another colleague on social media when you see something like that come up. Because I know we, as general practitioners, I always feel a lot better when a boarded ophthalmologist or the dermatologist comes along and says, "It's okay, you're doing it okay."
Well, I mean, the same is true for me, because I look at some of that stuff and I go, "Oh, I can help here. I don't know anything else," and I see general practitioners on some of these like sub whatever groups on Facebook posting these intense internal medicine things about the liver or whatever, and I'm like, oh my god, I don't know what I would do in that situation. So if I see an eyeball, I'm like, oh, I'm all over this. I can make this person feel better, but I wouldn't be able to do anything about orthopedic disease.
Yep.
That's not my ball.
That's all right. Everybody has their wheelhouse, and it's
Yeah, for
great. I'm
sure.
so glad that you're able to join us and go through this with us. I will tell you, I really want to try this approach because, like I said, I've always done the other one, and this has given me the confidence. I think my next one, I'm definitely going to try it, but I'm going to have the article open with all the beautiful pictures while I do it.
Yeah, for sure. Let me know if you have any issues, and I'll be happy to help you out.
I'd love that. Well, that brings us to the end of our educational content. But before we go, there is one last thing. We play a little game with our guests at the end of the episode. It's just a few would you rather questions. So do you want to play?
Oh, heck yeah, I want to play.
Oh, excellent. Okay. So would you rather practice without topical NSAIDs or without topical antivirals?
Ooh, I think I'd be hosed either way.
Really?
For me personally, oh, I I guess I will go topical NSAIDs, only because I'd be able to still use steroids.
Maybe yes. Substitute
And
some
if I didn't
steroids in
have
there. Yeah.
antivirals, I don't have anything for these herpetic cats. So yeah, I think that's where I'd go on that one. But that's a tough question.
I think for the patients, we'd have to probably go with the antivirals, although I would be sad if we couldn't say flurbiprofen, because I just like to say that.
All the drug names are awesome. It's so awesome. I love hearing clients' renditions of what they say. The other day, I had a client that continuously said Anapril for enalapril, and it just provided so much entertainment for me. I don't know. I look for the simple things to make me laugh during the day, but that stuff makes me laugh. So I agree. Flurbiprofen, tacrolimus, cyclosporin, they're all
so
fantastic.
Much fun to say.
Yeah.
Would you rather have an entire month of surgical cases or an entire month of medical cases?
Surgical. And that's an easy one for me.
I'd
rather be stuck in the OR for sure.
Okay. If you had to choose one, would you rather measure intraocular pressure on an alligator or a polar bear?
Ooh, that's a good one. I guess I'll go polar bear, but you're going to lose an arm one way or another.
I know. I think they're both so dangerous, but I'd probably go with the bear too, just to see one up close. Yeah.
Yeah, for sure.
If you could go back in time and repeat your residency, would you choose ophthalmology again, or would you try something different?
I don't think my mentors would let me go back and redo my residency. I think that I don't think they would have that. They would probably be like, I'm retiring, I'm out of here, I'm not dealing with DJ again. But 1,000,000% I would do ophthalmology. And I would love to actually redo my residency with all the knowledge that I have now to go back and work with my mentors that have more experience, and then be able to challenge each other on those cases. That would be a real fun thing for me. So if I could, if I had all the knowledge now and I got to go back and do surgery with Dave Wilkie and Ann Metzler and kick around these cases and provide an academic versus private practice sort of mentality, I don't know that I would leave the building. I think
they'd be stuck with you.
They'd be stuck. They probably like me even less. But no, I have a good relationship with my mentors, and so it's it's good. I would enjoy that.
All right, last question. Would you rather have eyes like a chameleon that can move independently, or would you rather have eyes like an Arctic reindeer that change color with the seasons?
So if you had eyes that change color, I think that people would find you more attractive and interesting. And if you had eyes that moved independently, I think you'd be accused more often of looking at things that you shouldn't be looking at. So I'm going to have to go with color changing, simply for the fact of not getting in trouble as much. But from a functional standpoint, I think it'd be a lot more fun to have independent eyes. So it's a split answer, but if I had to choose, I would go with color changing, just to keep me out of hot water.
I'd probably go with color changing too, but only because I don't want to see what's going on all over, because I have teenage boys. And so
no, you don't want to see
lots of times I'm like, no. I just don't want to see it.
No, head in the sand. You don't want, no, better off not knowing.
Well, that was all my questions. You did great. Thank you so much for playing. And thank you so much for joining us again. I know it's been a long time since we've had you on the show, but we definitely want to have you on again soon.
Yeah, you can have me anytime. I love doing this stuff. So yeah, for sure. It's always an honor, and it's fun. Makes my life better. So thank you.
Thank you for listening to today's episode. If you enjoyed our episode, you can find us wherever you listen to your favorite podcasts, including a video version now available on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcast episodes on our website at cliniciansbrief.com/podcasts, or drop us a line at podcasts@briefmedia.com. Clinicians Brief the Podcast is a Brief Media production, produced by Alexis, Ussery, and hosted by Dr. Alyssa Watson.